Has your doctor asked you to take a statin because you have diabetes? Have you wondered why, and even if you need to? Well, this episode is a treat because we have an expert on the subject.
Hey, welcome to the Diabetes Remission Roadmap podcast with the two renegade pharmacists, Brian Bisher and Corey Jenks. You are listening to this because you are a person with type 2 diabetes who is committed and driven to breaking free from this diagnosis and creating a real, meaningful change in your health and life. In these episodes, we're here to help you ditch the scripts with doses of unconventional wisdom on topics such as fitness, nutrition, medication, mindset, and more. So without any further delay, let's dive right in.
Welcome back to the Diabetes Remission Roadmap podcast. This is Corey, and Brian is taking a vacation this week because he deserves it. But I have someone way better looking and smarter with me today, who's another pharmacist who's going to answer your cholesterol questions. Austin Dudzinski is a board-certified clinical pharmacy specialist with interest in nutrition and metabolism and owner of the digital healthcare communications company, Digital Conversation. Austin is also a great follow on X and appears to be a much more skilled guitar player than me. So Austin, with that introduction, thank you for coming on and enlightening our audience about the world of lipids and cholesterol and statins.
Well, very happy to be here, Corey. I appreciate that. I'm sure your co-host has a little bit better hair than me, that's for sure. But
he has better hair than me too, and he reminds me of it all the time. It's a point of contention with Brian and me, but you know that's between him and me. So I want to cut right to the chase here. And that is a lot of times if you have type 2 diabetes, and this is our audience, your doctor says you must be on a statin. And sometimes I'll get the question when I was working in a clinic that my cholesterol isn't that high. So why do I even need a statin? And when someone has type 2 diabetes, we're told start a statin. Austin, explain why it's so important.
Yeah.
Or not. That's the
yeah.
I've sort of faded you into a corner there.
Yeah. So what I would say is that I think cholesterol metrics in and of themselves, they take up a lot of oxygen in the room. So providers like to see lipid metrics because they can run them on a very simple, cheap, easy lipid panel. And then there's a specific medication they can prescribe to manipulate that variable in order to see improved outcomes for an individual. So, just looking at the lipid metrics in and of themselves, some people are told, hey, I don't have or do have high cholesterol. Do I need to do something about this? Oh, my cholesterol is already low. Do I need to take a statin, et cetera? I think the best thing to do is to take a step back and look at the entire clinical picture of the individual. And one of the most profound risk factors that we have for cardiovascular disease is metabolic dysfunction, metabolic disarray. Issues with insulin resistance. And insulin resistance, of course, is the underlying pathology that drives conditions like type 2 diabetes. So type 2 diabetes tends to be this amplifier of all chronic diseases, tends to increase the risk of cancer, the risk of dementia, but most specifically, the risk of cardiovascular disease. Most individuals that have diabetes do ultimately succumb to some sort of cardiovascular event as far as the highest incidence of mortality in that specific population. So, throughout the history of evaluating evidence and what is required in order to mitigate risks in individuals that have diabetes, data has been compiled that would indicate that basically anybody over the age of 40 that has a diagnosis is at sufficient risk for cardiovascular disease that they would benefit from medications like statins, like lipid-lowering therapy. And what we know from multiple meta-analyses is that for every roughly 1 millimole or 38 milligrams per deciliter, we drop LDL cholesterol. That usually translates to a 22% roughly or so relative risk reduction in the risk of having a major adverse cardiac event, at least over about a 5-year period. And so the challenge that I run into as a clinician and I think you can sympathize with this, Corey, but I'm probably the most anti-medication pharmacist someone will ever kind of meet. It's not to say that I don't think that medications have a lot of value, because I do think that they do, but I think it's appropriate to use the right tool with the right patient at the right time. And with diabetes, it is a heterogeneous disease, meaning that, there are some folks that have a touch of diabetes and have rampant heart disease. There are other folks that have poorly controlled diabetes for their entire life or for 20, 30 years, and they somehow don't appear to have any sort of issues with that disease. So, when I'm looking at diabetes and using statins for these types of individuals or other cholesterol lowering medications, the big thing that I like to look at is imaging in conjunction with that diagnosis. Because I think imaging does a really good way of stratifying risks in a whole host of different populations, whether that's diabetes or people with high blood pressure or people that have abdominal obesity or people that suffer from other inflammatory conditions like rheumatoid or psoriatic arthritis. And that calcium score can really help us refine and determine who is likely to benefit the most from lipid-lowering therapy. And then likewise, too, who can we potentially, given a very important risks benefits discussion, who can we defer lipid-lowering therapy in to maybe focus on lifestyle and reverse that with nutrition?
Well, if you're listening, I'm going to tell you right now, Austin gave you a brief little nugget that probably most of your doctors will never talk to you about. You learned more in that 5-minute explanation than I think you might learn in many trips to the doctor. And I'm not trying to just butter Austin up. I learn as we go along with this. And so I think what Austin is, if I'm going to try to summarize this, and you tell me where I'm wrong, is that type 2 diabetes, the underlying pathology of type 2 diabetes, insulin resistance, basically takes an average person and makes them more at risk for heart disease. Now, some people, they will get that heart disease despite having sugars that are a little bit high. And some people will get no heart disease despite sugars that are crazy, that would put me in a big nap, so to speak. And the challenge comes is that when we see a condition that can cause heart problems, we have a category of medicines called statins that, and we're not going to make broad sweeping claims here, but potentially could reduce those risk of heart problems. When a doctor has that tool in their tool belt, we see risk A to prevent condition A. We're gonna use that tool. So is that why in an 8-minute visit we don't get a chance to talk like Austin did about all these risks benefits? So is this kind of what we're looking at? Is that when you have type 2 diabetes, yes, your risk of heart disease is higher. Yes, a statin could help, but you mentioned imaging. And I think this is a tool that I've talked about when I was in clinic with my patients. You mentioned a CAC score, giving us a better idea of risk. Austin, can you tell folks who've never heard of a CAC or sometimes called a calcium score what that is, what that does, and how that affects whether or not you might take a medicine?
Yeah, of course. So calcium scoring is a imaging modality using a CT scan. So it's a dry CT scan, so there's no contrast dye. It takes about 5 minutes to do, to be honest. Most patients that go in to get a calcium score, they're in and out of the entire visit in about 40 to 45 minutes. So it's remarkably quick. Most calcium scores are offered at very little expense, anywhere between $50 and $250. The institution that I work with offers them for $99. They're all cash pay, and that's pretty common with most insurance payers. Usually they don't pay out of pocket. The patients are usually paying out of pocket cash for these types of things. But when you get a calcium score, it's the dry CT scan of the chest, and it's looking for what's called calcified plaque. And so you may have heard through different medfluencers and social media accounts, calcified plaque is late stage disease. Once you have calcified plaque, you're way long gone because you already have heart disease or something along those lines. The bottom line is that, in my opinion, is just simply not true. Calcified plaque is a late stage portion of heart disease, but depending on the burden of that calcified plaque, how much you have in your blood vessels, that's really what distinguishes an individual's risk profile. So there's a big difference between having a calcium score of 1 and having a calcium score of 1,000. Now, when you look at a score, the score is given in what's called an Agatston score, named after the great Dr. Arthur Agatston, who would be an awesome guest on your podcast, by the way, if he hasn't been already. But he invented the South Beach diet. He tends to be a fairly big proponent of like lower carb nutritional approaches, protein, focusing on whole foods, a lot of the mantra that, I think me and you, Corey, certainly agree with. But that Agatston score is a composite of the evaluation of 4 different blood vessels in the heart. So it looks at the left main, the left anterior descending, the left circumflex, and then the right coronary artery. And each one of those arteries gets a value determined by a software. That's a number. And then those numbers are totaled up for a total Agatston score. And then based on the Agatston score, we can determine again how risky this individual is for developing a major adverse cardiac event over the next roughly 5 to 10 year period, at which someone may elect to get rescanned. One of the cool things about calcium scores is that when you fire off a 0, that generally portends a remarkably low risk of cardiovascular disease, irrespective of the risk factors that you have associated with it. So, for example, when we look at diabetes in particular, individuals that have a calcium score of 0 tend to have a lower incidence of events, even in the context of type 2 diabetes, over a 5 year period, compared to those that don't have diabetes, but have a calcium score greater than 100. So that just shows how helpful calcium is in risk stratification. Again, diabetes being a very heterogeneous or very mixed bag of risk associated with it. And therefore, the calcium score is there to refine it.
Yeah, what I love about the calcium score is that it shows my age. Because I don't know how old you are, Austin. I'm 39 years old. I graduated pharmacy school in 2011. I had to think about that. And when I was going through school, doing my residency, going through into my practice, we didn't really talk about a calcium score. We just had these risk calculators. And they used various risk factors, blood pressure, cholesterol numbers, I think I said smoking status, and it gave us this percentage. And based on this percentage, you gave a statin, or you gave a huge statin, or in a small number of cases, maybe no statin. So what you're saying is now we have more tools. If you're listening to this, you have more tools beyond just the cholesterol numbers. And so we've kind of talked about the degree of risk that diabetes confers. We've alluded to cholesterol numbers. We've talked about the CAC score. Let's take a step back and break it down to the basics, because I think I might have glossed over this. Can you tell the listener, when they get a regular old cholesterol or lipid panel, what those numbers are, what they mean, and what their doctor might be looking at? And I'm gonna lead you somewhere, but maybe there's a non-traditional number we want to look at that could tell us how we're doing with our metabolic health or insulin resistance.
Yeah, for sure. Yeah, so I think, it really depends on the individual that you're speaking to and the provider that you're speaking to and how savvy they are with respect to understanding the nuances that come into a lipid panel. Um, when you get a lipid panel, typically there are a series of numbers that are spit out. Usually there's a total cholesterol, there's a triglyceride level, and then there are subfractionations of this total cholesterol. Usually there's an HDL cholesterol and then an LDL cholesterol. Every once in a while, you'll get a VLDL cholesterol. We could talk about what that is.
Mhm.
You also may get a non-HDL cholesterol. And then there's a couple of ratios that sometimes they'll spit out. Most clinicians, I would say, tend to really hone in on the LDL cholesterol, because the LDL cholesterol is an actionable item that they can use a medication for to ultimately manipulate and therefore lower the risk for an individual. I would argue that that is not a great strategy for evaluating a lipid panel. In fact, quite frankly, unless your LDL cholesterol is remarkably high, and it's not induced by some sort of dietary state, for example, like a lean mass hyperresponder, a very lean individual that adopts a low carb diet sometimes can see their LDL cholesterol go very, very high. So unless you have a genetic abnormality or some strange secondary phenomenon where your diet has induced a remarkably high LDL cholesterol, that number, I really just don't care about it that much. And here's why.
Yeah, because this is
You know,
controversial. I want you to
yes,
explain this, because everyone who's ever gone to their doctor has basically been told LDL bad cholesterol, and so you're uh, this is a little controversial, Austin, and it's not
it
normal
is.
for a pharmacist to get this spicy, and I'm here for it. So
I,
let's hear it.
let's get really spicy. So here's the deal. I think LDL cholesterol in and of itself is a remarkably poor risk predictor, meaning that if you look at a value of LDL cholesterol, it really does not tell you how likely this person is to develop a heart attack or a stroke, uh, at least over a 5 to 10 year period. there is this ongoing idea of this cumulative exposure, kind of like a pack history in smoking,
Hmm.
where you take the number of packs that you smoke per day and you multiply that by the time that you've smoked, and therefore you have some sort of threshold that determines, what your cumulative burden of smoking is. The same kind of holds true in some of the mainstream lipidology. There's this cumulative exposure with respect to LDL cholesterol and time that you've had your LDL cholesterol at a certain value. So the challenge is that with LDL cholesterol, let's just say it's less than 70. If you were to take a snapshot of people that had an LDL less than 70 and thought to yourself, how many of these folks have a significant amount of cardiovascular disease? Most people will say, well, none of them have cardiovascular disease. Their LDL is below 70. That's like, below the fifth percentile. They have the lowest LDL cholesterol in the population. There's no way that any of these individuals have any sort of clinically relevant heart disease. The challenge is that when we actually look at that data, what we find is that about 30% of individuals that have an LDL cholesterol less than 70, while not being on a statin, so this is individuals that are not taking medications, LDL cholesterol less than 70, about 30% of them have a positive calcium score above zero.
Hmm.
1 in 3 almost. And then if you look at that data a little bit more granularly, you find that 1 in 12 have a calcium score greater than 70, or excuse me, greater than 100, which is a really important clinical cut point for portending a little bit higher risk for that specific individual. Likewise, too, when you look at other studies like Western Denmark Heart Registry, what we find is that if you contrast LDL cholesterol greater than 193, which is very, very high, to less than 116, what we find is that in the context of a calcium score of zero, there is no difference in the incidence of events between those two individuals. In other words, they have the same rate of heart attack, stroke, cardiovascular disease, whether your LDL cholesterol is very, very high versus very, very low. If you take your LDL cholesterol and it's less than 70, but you have a calcium score above 100, you have about a 9-fold higher risk of heart disease than an individual that has an LDL cholesterol above 130, but a calcium score of zero. Okay, 9-fold higher risk. So that just goes to show how poor of a risk predictor LDL cholesterol is for determining candidacy for lipid-lowering therapy or otherwise. Of course, barring the strange genetic abnormalities or
Hmm.
other
Yeah.
goofy things going on.
If you've been told you have familiar hypercholesterolemia, talk to your doctor. That's a totally
Yes.
different world. So, in a sentence, LDL cholesterol matters, and it kind of doesn't, but it does. But context matters, and it hits home for me. My dad had a heart bypass a couple years ago. Never had a particularly high LDL. Never had high blood pressure. Lifts weights, active, no stress, other than me being his son. But he has a history of ulcerative colitis. You talk about those autoimmune conditions, which I'm going to put a pin on. I'm going to talk to you. We're going to have another episode on autoimmune and lipids and heart disease. So what we're giving you as you're listening is this is like cutting edge stuff. This is stuff that was not in my toolkit coming out of pharmacy school. So if you have a high LDL, it does not mean you should run scared. And if you get a CAC score, it does not mean you should run scared. All of this is to say, and we have the disclaimer at the end, Austin, don't you worry, that this is a conversation with your provider. We're trying to provide you some tools and education to better understand where you fit in this world, why diabetes matters, why your doctor cares about LDL, why LDL matters, and what else matters. Now, there's a ratio I like, and it was sort of like my crystal ball for if someone was going to develop type 2 diabetes. And so the one I look at that I like, and you tell me what you think of this one, is triglyceride to HDL ratio. Because I would have people in my clinic who were confidently walking around without high sugar numbers, a good A1C, we're pushing high fives, and now we're pre-diabetes, but they're like, I'll be fine. But their triglycerides were super high, and their HDL was very low. And it was almost like inevitable within a year, I would see an A1C in the teens. Can you give us a brief overview? Because we've talked about LDL, the discussion to have, the context with CAC score, but there's triglyceride to HDL ratio is sort of like, I kind of like it. It's kind of my little pet friend or project there. So what can you tell me about triglyceride to HDL ratio?
Yeah, so I love the triglyceride to HDL ratio. I think it is a really valuable metric. There are certainly limitations to it.
Mhm.
So, for example, in Black populations, triglycerides can be very, very low, and they still may have rampant insulin resistance or have that underlying pathology that's driving conditions like type 2 diabetes.
Mhm.
So there are some important caveats with that. The other thing too about HDL cholesterol in particular is that it's probably more helpful to look at a trend in HDL cholesterol rather than a single nominal value. Some people will get lab results of a high HDL cholesterol and think, oh gosh, I'm protected from heart disease. My HDL cholesterol is taking all this cholesterol out of the plaque and making sure that that plaque doesn't rupture and doing all the good things that HDL does, and therefore I'm protected. And what we find is that actually individuals that have remarkably high HDL cholesterol, usually north of 80 milligrams per deciliter, tend to have it tends to be more of a marker of a dysfunctional HDL particle that is just not doing its job as appropriately. So, barring all of those little limitations with the triglyceride HDL ratio, I think it is by and large a very good screening tool. Says like, hey, we need to dive deeper.
Mhm.
Here's the big thing though that I think is remarkably important for people to understand is that triglycerides above 150, which is what is flagged on a lab as high, is very high. In fact, I would argue that triglycerides much north of 100, probably much north of 70 or 80, are starting to trend into a suboptimal category of risk for
Mhm.
that particular individual based on their genetic predisposition to the development of cardiovascular disease. So, again, like we had talked about earlier, with diabetes being very variable as far as how much that risk is portended by that, I usually say genetics loads the gun and environment pulls the trigger. And if someone has just a teeny tiny elevation in triglycerides above being optimal, they are suboptimal and they may ultimately be at risk. So my kind of cut points for triglycerides are probably anything north of 70 or 80.
Mhm.
I'm starting to be a little bit more concerned about insulin resistance, at least impending. And then based on where that relates to the trending values of HDL, not looking at it as an isolated metric, but basically how it changes over time in relation to the triglycerides, I think that that is remarkably valuable. Most people will use a cut point of 2 or 2.4 to kind of denote a high triglyceride to HDL ratio. I would argue that anything north, again, of about one or so, which might be kind of controversial, I would argue is likely suboptimal. And there are many cohort studies that look at what triglyceride level portends the lowest risk for people. Typically, it's below 50, and you might be kind of surprised to hear that. But go ahead.
Yeah. Well,
Yeah.
no, I was going to say, I think so. If you're trying to figure out the calculation, you take your triglycerides divided by your HDL, simple division, or not for so simple for us who now have to use our phones for every piece of math that we do. But it's a quick marker, like Austin was saying, like I think of for insulin resistance, for energy toxicity in the body. And so 150 is the marker on the labs, but as Austin was saying, we want to see that as low as possible. Now, we're not here to give medical advice. We're here to give education. We didn't talk a lot about specific LDL cutoffs. We did give some specifics on what to look out for kind of weird stuff on higher HDL, where to look for triglycerides being lower, which I think maybe tells you where our heads are at with what we think lipid parameters confer risk. We talk more about triglyceride numbers than LDL numbers. But you said earlier that you might be the most anti-medicine pharmacist ever, and Brian and I would like to challenge you to a cage match. Just kidding. So, to bring us home here, for someone listening who wants to lower their cardiometabolic risk, what are the things that matter the most, regardless of medications? We're not going to tell you whether or not to have to take that statin. That's a discussion with your doctor. Hopefully, you have some tools. But Mr. No Medicine here, Austin, take us home. What do we want to be looking out for? What can we do? What action can we take?
So I think it kind of depends on the situation of the individual. So I think if this individual is demonstrating any sort of markers of insulin resistance, whether that be slight elevations in triglycerides, maybe for a future podcast we can talk about this too, Corey. But there's a metric called C-peptide that I
Mhm.
really like, which is a basically a marker of how much insulin is being secreted by the pancreas. And this often precedes triglyceride changes by 5, 10 years. So sometimes people can have optimal triglycerides, but still have high blood levels of C-peptide. And again, I would argue that those individuals are at higher risk. And so if we're starting to see any of these types of evaluations that point towards insulin resistance, then I think nutrition and lifestyle modification is something that is remarkably important. And the name of the game is really weight loss, oftentimes specifically fat loss, and specifically fat loss out of the viscera, which is the area of the body, the internal cavity of the body that houses the organs. And when we have a lot of what we call visceral fat, that usually portends a significant amount of cardiovascular risk and metabolic dysfunction to come. So with respect
Which
to
for the yes, which fatty.
yeah,
If you've ever been told you have fatty liver, we're talking fatty liver, fat around your pancreas. Continue.
right, exactly. So fatty liver, fatty pancreas, we call that type 2 diabetes.
Hmm.
When we have enough fat in the liver, when you have enough fat in the pancreas, that is what actually tends to drive, based on the twin cycle hypothesis put forth by an individual named Roy Taylor, who has great books, by the way, very excellent published physician out of Newcastle. He basically identified the fact that when we can mobilize fat out of those two organs, we find that the risk of the progression of type 2 diabetes is largely negligible.
Quick pause for a second, because if you're listening to this and thinking, okay, but how does this actually apply to me? We want you to know you don't have to figure that out alone. If you're on diabetes medications, your A1C is high, or even if it's in range, and you still don't feel good about where things are headed, we offer a free diabetes medication exit strategy call. We'll help you understand what's driving your blood sugar, what's realistic for reducing or stopping medications, and whether a real exit strategy makes sense for you. You can book it anytime. Link in the show notes. All right, let's get back to it.
So with those individuals, I think the name of the game is to really try to get fat out of the liver, fat out of the pancreas. And unfortunately, I wish there was like an excellent way to perfectly target those specific organ systems in order to mobilize fat out of them. But really the bottom line is these individuals oftentimes need to try to lose fat mass and or build muscle mass.
Oh my gosh.
And so
it's like you've been listening to our podcast. Austin.
yeah, there you go. There you go. And so with that, I think there are a lot of different pathways to health. I think there are many different ways to achieve fat loss for an individual. I think in the context of type 2 diabetes, what tends to be fairly clear is that individuals tend to respond probably better on aggregate to lower carb nutritional approaches than, let's say, lower fat, Mediterranean, DASH, or other types of dietary permutations. That doesn't mean that it's the only way to do it, but it does mean that if we're looking at a first-line strategy for weight loss in the context of type 2 diabetes, I would argue that low carb or ketogenic or very low carb dietary patterns tend to be remarkably effective in that population. The other thing that's important to note too about those permutations of diets, which oftentimes holds true for most minimally processed food containing diets and most adequate protein containing diets, but specifically with low carb or ketogenic diets, what we find is that these individuals can eat until they're comfortably full and they ultimately can lose weight. And I think that is remarkably important because when you're told to put down the fork or try to just power through hunger, that is something that is largely just not sustainable for most individuals. And so trying to cultivate a dietary pattern that they can eat until they're full, that they enjoy, and that they can lose weight on or optimize their body composition on is something that I always try to strive for. And sometimes that cashes out to individual preference.
Yeah, I love that advice, and with the diet advice that Brian and I ascribe to, and I'm a little more closer to the low carb world. But essentially, as you say, can we eat in a way that makes us feel fuller, that reduces the excess energy toxicity and insulin resistance going on in our body? And low carb, as you say, it's not the only way, but it's a very good way, and it's a way that I think we've seen and many of the people we've taken care of have remarkable results in ways that they never saw happen before on a low fat or a DASH or whatever type of diet that is. So, Austin, you are a busy, important man. I could tell by your rock star headphones. So we are going to have you back because there's so much more to unpack in the world of cholesterol. If you want to tell folks where they could find you, I will have your links in our show notes as well. But if you want to verbalize it, any last words, and then we will let you get on with your day and hopefully have you back soon.
Well, I really appreciate you having me, Corey, and this was really fun to chat. I think we do have a lot of things that we could go into detail about. Um, so people can find me on X. I post quite a bit on X. Corey, you can attest.
Mhm.
My handle is at ApoDuds, APODUDZ. People can find me on LinkedIn if they want to DM me on LinkedIn or whatnot. Certainly DM me on X or formerly known as Twitter. And then I'm sure Corey will put in email addresses and other things like that. So, but yeah, I'm happy to help in any way. And I really did enjoy the time and would love to come back on and we can kind of unpack some of the stuff in more detail.
Well, excellent. Well, as you listen to this, write your questions down, and we'll get Austin back here to answer more cholesterol questions. I know it's one of the most contentious things in the world of type 2 diabetes management. But until then, thank you for listening to the Diabetes Remission Roadmap podcast. Until next time, have a wonderful day.
If this episode gave you clarity or hope, share it with one friend who's been stuck in the diabetes trap. That's how this mission grows. One person, one family, one story at a time. And if you haven't yet, leaving a quick review helps more people find the show and realize they're not stuck with meds forever. It takes less than a minute and it means the world to us. Thanks for being here and thanks for being part of this movement toward freedom. Thanks for listening to the Diabetes Remission Roadmap. The ideas discussed here are for general informational purposes only and do not constitute medical or nutritional advice. We are pharmacists, but we're not your personal healthcare providers. Always consult your own physician or qualified clinician before changing medications, exercise routines, or nutrition plans. Results vary, and what works for one person may not work for another.